MRP Fusion was a term that popped into my mind the first time I experienced the three medical radiation professionals working in the same clinical space. I realized that technology had provided an overlap in the tools of our trade. While attending the RSNA in 2007, I had a chance meeting with the man who pioneered hybrid scanning, Bruce Hasegawa. He developed the algorithms to co-register SPECT and CT images. This concept led to the development of PET-CT and PET-MRI scanners and dual-modality cameras marketed throughout the world. We spoke of the increased diagnostic accuracy achieved with hybrid imaging, but did not foresee how it would bring together three distinct professional groups. This combination creates a seamless diagnostic and therapy planning service for the patient. We service a large geographic zone from Cairns to northern New South Wales. Patients in one hospital visit can have 3 procedures and only one fast. They obtain precise, quantifiable, functional, anatomical and molecular information for staging and treatment with the lowest achievable radiation dose. This is an example of optimal multidisciplinary care. This was a routine we used regularly for patients travelling from northern New South Wales by transport. The patient could leave home at 6 a.m, arrive at radiation oncology at 8 a.m, have their mask fitting. At 8:15 they would go to the CT for their planning CT with the mask in situ. 8:30 they would present to the PET scan department for their FDG injection. The PET scan plus the diagnostic CT was performed at 9:30 a.m. The RTs would come for the planning PET, fit the mask for the head and neck views. The patient was then able to have breakfast at 10:30, a med-onc review at 3 p.m. after much of the radiation had dissipated. Transport home was arranged for 4 p.m. and they would be back home by 6 p.m. As our cameras have full diagnostic capabilities, it was decided to provide funding for diagnostic radiographers as part of the staffing mix. We have a PET-CT and PET-MRI used for routine clinical imaging on a daily basis. Experienced medical imaging technologists work with nuclear medicine technologists to perform the diagnostic CT and MRI components of the scans using contrast media. Imaging protocols use the same parameters as in the CT and MRI departments upstairs for consistency and ease of reporting. This enables a wide range of CT and MRI examinations to be performed at the same time as the PET scan, reducing the need for patients to have multiple visits to the hospital and can all be co-registered with the PET data. As PET-MRI is a relatively new modality, it means developing new protocols employing different MRI sequences can be done quickly, and it does not involve radiation and can be acquired at the same time to achieve the best diagnosis of pathology and extent of disease. During the planning phase of our PET department, I attended a radiation therapy conference as it had many presentations involving PET to help me gauge their requirements from our scanner. This led us to including the other medical professionals in the planning process. The RT input ensured that the data from our scans was compatible with their planning software, and the position aids and laser alignment system was the same as they use, saving time when they came around to perform the planning PET scans. The purchase of the pressure injector and CT contrast used in the department are the same as in the CT department upstairs. It was very helpful with room design and selection of the appropriate coils for the variety of MRI examinations, and this was all done in consultation with the MRI department. Diagnostic and CT MRI examinations can be performed during the first patient's uptake period by the diagnostic radiographers, reducing the waiting lists in the main radiology department. One important outcome, as we experienced recently, was it allowed the nuclear medicine to draw from a large pool of staff to maintain our PET service during staff shortages, e.g. pandemics and natural disasters. Overall, patient and staff safety was increased with this staffing mix. The nuclear medicine technologists ensure correct tracer and activity is administered to the patients. They deal effectively with radiation spills. They remind the other staff of time and distance and monitor their electronic personal dosimeters. They also use the correct mobile shielding. The medical imaging technologists have greater experience with contrast reactions and their risk factors, whereas the MRI radiographers bring safety for the staff and patients. Their vast knowledge of implants and their compatibility to magnetic fields, as well as well-established procedures and safety questions prior to scanning, not to mention the ante-room final checks. We also have a large equipped uptake room for resuscitation and dealing with contrast reactions, so workflow can be maintained on the scanner. Historically, accreditation from professional bodies provided eligibility for the various classes of radiation licenses. After hard work by the technologists and our professional bodies, our profession was recognised with national registration through APRA and a new framework emerged. Radiation Health issued revised eligibility requirements due to the advent of these new scanners. Requirements vary depending on the industry you work in and the category of the radiation source you apply for. A suitable person must hold the accreditation. You must hold the relevant qualifications and training, obtain a criminal history and security check, and hold the relevant skill, competency, knowledge and experience. Again, this is another area where Australia is quite progressive. When I was at the RSNA, there was only 3 countries that had purchased SPECT scanners with diagnostic CTs: Australia, France and Denmark. The other countries were still struggling as to which department to place the scanners in. Comprehensive MRP Fusion is achieved by furnishing training programs with a common curriculum that allows trainees the flexibility to focus on expected areas of practice and is approved by appropriate nuclear medicine and radiology professional bodies and government bodies. This has certainly been achieved in Australia with nuclear medicine graduates eligible for a diagnostic CT license upon completion of their course. Supervision by skilled mentors is required to develop a strong foundation of PET, CT and MRI expertise in the clinical setting. CT, ultrasound and MRI are now in the general domain, and nuclear medicine technologists are eligible to seek further qualifications in these areas. This creates a more robust workforce ready for future advancements and greatly enhances employment opportunities for those who have undertaken the extra studies. I myself gained my nuclear medicine accreditation and required licensing by completing a postgraduate diploma. At the Princess Alexandra Hospital, we regularly visit vascular and interventional radiology to deliver tumour treatment using CERT, and the ultrasound department of peritumoral lymphoscintigraphy following hook-wire insertion. The diffusion of knowledge I have experienced in the department is happening in MRI and CT as the staff that work in PET pass on their experience, and the superimposition of radioactive tracer on CT and MRI images viewed as a contrast agent to help them better perform diagnostic imaging with pathology clearly demonstrated on the fused images. I see further MRP fusion in the emerging field of theranostics. To fully exploit the potential of theranostics, not only must RTs, NMTs and MITs collaborate with each other, nuclear medicine physicians, radiologists, radiation chemists and medical physicists must be integrally involved in patient care. In conclusion, I would like to refer to a quote from our old friend Socrates, and this is relative to the patient's experience. The whole is greater than the sum of the parts. I would like to thank Sarah Daniel, the statewide educator, for bringing my presentation to the 21st century, Mick Cheers from Siemens, and Penny Holmes from PAH Media for providing images, and all the people I work with for their commitment and compassion. Thank you.